Okay, we're live, and good evening, everyone, and welcome to another study session with me. I am your host, and for those who are watching on the World Wide Web, I am Kevin Vassiana. I have a master's in healthcare administration from Capella University, bachelor's of arts degree from St. Thomas University, and I have my certified coding specialist from AHIMA. I run these study sessions on a weekly basis to help coders throughout the industry. And tonight we're going to be looking at evaluation and management coding along with anesthesia coding. And I have a full class, so you will hear interaction in the group as well. So we're going to go back over what we discussed for those who were with us last week, Monday. And we're just going to do a quick recap of what we discussed last week. The coding system was first developed in 1966 to report medical and surgical procedures. The 3 editions of CPT was published in 1970, 1983, CMS Center for Medicare and Medicaid Services, formerly known as HCFA, or Healthcare Financing Administration, was incorporated, they incorporated both the CPT codes and HCPCS codes. And so pretty much what happens is they develop a 3-level system. Level 1 is for CPT, level 2 is for HCPCS, and level 3 is for level 3 codes. So it's a 3-level system. So let's look at a brief overview of HCPCS level 2 codes. As with CPT, the HCPCS level 2 codes are standardized similar products and categories for processing a medical claim. The HCPCS codes are primarily used for billing and identifying items and services. These items and services primarily are like ambulances, prosthetic devices, drugs, all of those stuff are classified in the HCPCS manual. Okay. These are the different divisions of the HCPCS manual. The codes will find, you'll find transportation codes in there. You'll find peritoneal therapy codes in there. You'll find temporary hospital OPPS codes in there. You'll find DME equipment codes in there, which are the E codes. You'll find G codes, which are temporary codes, and some of them, as discussed last week, are utilized for physician services. Age codes are for health and substance abuse services. Okay, these are some additional codes that is out there. You have J codes, which are drugs administered other than oral method or chemotherapy codes. You have K codes, which are temporary codes for DME, regional carriers. You have L codes, which are utilized for prosthetic procedures. M codes, which are other medical services. P codes, which are pathology and laboratory, and S codes, which are temporary codes, and T codes, which temporary codes but Medicaid driven, Medicaid agency driven. So that's going to be driven by state because Medicaid is per state. And you're going to have your V codes. The V codes are for vision and hearing services. Okay. As discussed last week, the dental services, they have their own D codes, which is for dental CDT codes, right? They have their own manual that they utilize. It's pretty much an easy set of coding tool that is out there. It doesn't take a rocket science to figure that out. You just open up the book and you look for the code that you need for CDT. It's so easy that majority of the coding that's done in those organizations, dental offices, are pretty much done by the receptionists. They're the ones who you'll see do it. Okay. All right. You have your L codes.
Barbara, turn it down.
Roz, I'm going to need to mute your mic, please. Roz?
Can you mute your mic?
Okay, you have additional things that you need to remember in regards to the CPT manual. These are your modifier 51 exempt codes, your new modifier, your new procedure codes, the add-on codes, your revised codes, your newer revised text, and you have the out of numeric sequence codes. We went over that last week as well. Okay, so I'm just briefly doing an overview. Okay, so class, you remember that you have three factors that influence the E&M codes, right? And they are place of service, type of service, patient status. Okay, place of service, type of service, patient status. What is an example of a place of service? Let's see. Let's ask Sandria. What's an example of a place of service? Sandria?
I'm sorry.
Example of a place of service.
Nursing home.
Right, exactly. And let's ask Brittany. Brittany, tell me what is an example of a type of service? Brittany, are you with me? Okay.
I'm sorry, a consult or an admission.
Exactly. And patient status. Christina, what is an example of a type of patient status? Okay. Is Christina not there? All right, let me go to somebody else. Delona, help me out. What is the example of a patient status?
New patient, application.
Very good. So those are my three factors that influences E&M codes: the place of service, the type of service, and the patient status. So when you look at a medical record, those are the three key things you need to identify with before you open up that CPT book. That's what I would want everyone to practice before you get into that that book. Make sure you have your your three factors of E&M codes open up. Okay, so place of service, type of service, patient status. You identify that in the medical record that you're looking at, and then you go for it. Okay, for the most part, if you're working for a doctor's office, those three questions will be identified for you. You will know exactly what it is that you're doing. Okay, you will know exactly what place of service you work at. You will know if you work for a consultant or emergency department, that kind of thing. So that key question is answered for you. If the type of service, whether it be consultation, that will be answered for you because you know where you work at. And the patient status, right? That's the only thing you probably would need to procure if you work in a doctor's office. You need to know whether or not this is a new patient or an established patient. Okay. If you're in a hospital, you have to worry about whether this is an inpatient case or an outpatient case. Okay, as we all know, we have two set of coders in the hospital sector. We have an inpatient coder and we have an outpatient coder. You do have coders who are out there who do code both inpatient and outpatient. All right, so but for the most part, most hospital HIM departments are set up to have an outpatient coder separately and an inpatient coder separately. So they only have to rely on those two separate rules, and they don't confuse or conflate the two when they're trying to code. Okay? So the patient status, new patient, is one who has not received professional services from the physician or other physician of the exact same specialty and subspecialty in the same group within the past 3 years. So that's the key. The years, 3 years, have not been seen within the past 3 years. It could be 3 years and a day, and that patient would still be considered a new patient because they went over that threshold. They went over that that 3 year mark by one day. So that's what you got to have to remember. And established patient is a patient that is pretty much been with the same group, same specialty, and they've been seeing the same group, same specialty within a 3 year mark. And so that is a established patient. So that patient now we don't have to worry about, we're trying to classify them as a new patient. In a hospital or facility setting, we look at outpatient visits. Outpatient visits are considered to be anyone who's not formally admitted to a hospital, right? Not formally admitted to a hospital. It could be being treated in an ER. It could be treated in the wound care clinic. You could be treated in the observation wing. You're not formally admitted, so therefore you're considered to be an outpatient. Inpatient, we know the classification stems from somebody who's formally admitted to the hospital. So you're definitely in the bed. You're there most likely over 3 days plus, or you just have an admittance sheet in your medical record that says you're formally admitted to the medical record, to the hospital, that is. Okay, so with that information at arm in hand, as a coder, you will know what the classification is that you're going to be coding for that particular visit. You know you're going to be coding an inpatient stay, and you need to now rely on how many days was the patient there for, what's the primary diagnosis or principal diagnosis for this patient. Make sure you have all the pertinent factors in play to make sure you're going to code this medical record right on the first go around. So on this grid, as you can see, the questions that's going to be asked of you is whether or not the patient has been seen by the same specialty within the last 3 years. And if the answer is yes, then this next question you need to worry about, is it the same subspecialty? And if the answer is yes, then we go down to the next question. Was the patient, is the patient established? And if the answer is yes, you know it's an established patient. If the answer is no, it's a new patient. So those are the kind of questions you have to drill in your head when you're looking at a medical record, because you need to make sure you're classifying it as correctly, new versus established. And last week we went over the 3 key components of the E&M, and we said they are history, exam, medical decision making, right? 3 key components. And then we also says that we also have additional components: counseling, coordination of care, nature of presented problem, and time. Those also play a factor. Okay. We tell you that in order to determine a history, there are 4 types that we need to worry about, whether it be a problem-focused history, an expanded problem-focused history, detailed, or comprehensive. And we went over the different subsets that's relevant to those type of histories. Okay, we talked about examination, and we talked about the different levels of examination, that being problem focus, expanded problem focus, detailed, and comprehensive. Problem focus, expanded problem focus, detailed, and comprehensive are the 4 levels here that we have to worry about. Okay, with the medical decision making, we also went over this, and we said that you pretty much have 4 levels to think about: straightforward, low complexity, moderate complexity, and high complexity. Within those 4, these are the factors that you have to worry about. You have to worry about whether or not how many number of diagnoses or management options there are. You got to worry about how many amount or data complexity is there to be reviewed. You have to worry about or review the risk of significant complications, morbidity, and or mortality when you look at that medical record. So you're looking at those factors to figure out whether or not the visit is going to be considered minimal, limited, multiple, or extensive for number of diagnosis management options, minimal, limited, moderate, or extensive for amount of complexity of data to be reviewed, or minimal, low, moderate, or high for the risk of significant complications, morbidity, and mortality. So those are how we're going to look at this when we trying to classify what is the level of the MDM. Okay. With that said, I told you last week that there's two sets of E&M guidelines out there. There's the 1995 exam guidelines and the 1997 exam guidelines, right? The difference between the two, the 95 guidelines are extremely generalized. The 97 is specific exam for specific specialties, okay? 95 allows the provider to complete the physical exam by documenting the organ systems or body areas. And the approach is quite subjective and gives providers a lot of leeway and wiggle room. The 97 guidelines, basically the E&M guidelines are rigid and forces providers to document the exam using specific bullet points. Exam rules are much more black and white with the 97 guidelines. And I believe I told you the one that is typically utilized in the doctor's office is the 97 guidelines. But you'll find that out when you go on your job site. They will tell you what guidelines they look at when you're, when you're reviewing your charts. And something that we're going to go over tonight too, further on down the road, is we're going to talk about the 2021 change that's upcoming. So look out for that presentation here in a second. And I gave you all a copy of the worksheet, an example. And we will also last week had you draw out, on your own, what the three key components will look like when you're trying to work with it. Something that you guys need to practice because it's good practice, especially when you're doing the CPT test, CPC test. You can be able to, kind of have that in your head mindset as how it should look and what are you trying to drive at, right? And I give you an example of a worksheet currently that is being used. So this is going to be for now until the end of the year, and then things are going to get changed. And we'll talk about that in a second. Okay, and we went over an example of a 99231 level where we have a patient that has a problem focus history, and the patient is coming in for a follow-up of a nephritis. And we know it's a problem focus history for level 1 hospital progress note. And so that's we are able to determine the place, the type of service, and all that good stuff. And we define it to be 99231 as a code of choice for this visit. We also went over the scenario, and we're not going to go back over that tonight. All right, so now we step forward into 2021. In 2021, this is what we're going to be looking forward to. CPT terminology for 2021, the office or other outpatient visit evaluation management guidelines and code descriptors will be significantly be revised. Due to the widespread use of these codes and the scope of the changes, information is being distributed early to facilitate formalization in the advance of the effective date. So table 1 here is showing a summary of the current typical times for new and established office or other outpatient visit E&M codes, as well as the time ranges that will become effective January 1st, 2021. Okay? Currently, we are utilizing 99201. In 2021, 99201 will be deleted. We will no longer use that code. The time span for 99202 is currently 20 minutes. In 99202 for 2021, we're looking at 15 to 29 minutes, and so forth. So 99203, 30 to 44, 99204, 45 to 59, 99205, 60 to 74 minutes time span. So time is a prevailing factor in 2021. Everybody see that? Okay. So effective January 1st, 2021, with the exception of 99211, time alone may be used to select the appropriate level of code for the office or other outpatient E&M services. Time alone. So history, exam, medical decision making really gets thrown out the door. So time is going to be my prevailing go-to when I pick up that book for these code sets. Everybody following? Any questions? Okay, hearing none. All right, so time is to be calculated for these codes based on the total time on the date of the encounter, including both the face-to-face and non-face-to-face time personally spent by the physician or other quality healthcare provider. Time ranges specified in each code descriptor are discrete and non-overlapping, providing concrete guidance when total time is employed as a key selection criterion. Note that time will be removed as an available code selection criterion for code 99211 effective January 1st, 2021. So at some point in time, your office that you work at, if you're doing E&M coding, they will update you again on the guidelines. So you will have probably formal education to kind of go back over what we're going over today. All right. So I'm just giving you a brief synopsis of what's happening. So they said the CPT 2021 E&M service guidelines section will include guidelines common to all E&M services, as well as guidelines specifically for office or other outpatient services and for the remaining E&M services. It's important to review the instructions for each category code or subcategory of the E&M services to ensure appropriate selection. The 2021 office or other outpatient E&M coding changes indicate that calculation of total time spent by the physician and other qualified health professional on the day of the encounter for the purposes of code selection may include the following activities, whether the activities are face-to-face or non-face-to-face. So it could be preparing to see the patient, obtaining or reviewing separately obtained history, performing a medically appropriate examination or evaluation, counseling and educating the patient family caregiver, ordering medications, tests, or procedures, referring and communicating with other healthcare professionals, documenting clinical information in the electronic or other health record, independently interpreting results, and communicating results to the patient family caregiver. Care coordination is also when not separately reported. So, clinical staff time and E&M code selection. CPT defines a clinical staff member as a person who works under the supervision of a physician or other qualified healthcare professional and who's allowed by law, regulation, and facility policy to perform or assist in the performance of a specified professional services, but does not individually report that professional service. The E&M service for which these time-related guidelines apply will require a face-to-face encounter with a physician or other qualified health professional. That's what QHP means. Time spent by clinical staff may not be included in the calculation of total time for the purpose of code selection when a physician or other qualified health professional performs the face-to-face services of the encounter. Clinical staff time is included in the practice expense calculation. When reporting code 99211, office or other outpatient visit where the physicians or other qualified health professionals' time is spent in the supervision of clinical staff who provide face-to-face service rather than performing the work themselves, time should not be used for code selection. Okay? In conclusion, Here are the highlights of the 2021 changes that I need you to remember. We will eliminate the history and physical as elements for code selection. While a physician's work in capturing the patient's pertinent history and performing a relevant physical exam contributes to both the time and medical decision making, these elements alone should not determine the appropriate code level. The work group revised the code descriptors to state providers should perform a medically appropriate history and or examination. It allows for physicians to choose whether their documentation is based on MDM, medical decision making, or total time spent on the date of the patient encounter. MDM, the work group did not materially change the three current MDM subcomponents. However, edits were made to the elements for code selection and revised, created numerous clarifying definitions in the E&M guidelines. Time. The definition of time is minimum time, not typical time, and represents total physician qualified healthcare professional time on the date of service. The use of date of service time builds on the movement over the last several years by Medicare to better recognize the work involved in non-face-to-face services like care coordination. These definitions only apply when code selection is primarily based on time and not MDM. Deletion of CPT code 99201, the panel agreed to eliminate 99201 as 99201 and 99202 are both straightforward MDM and only differentiated by history and exam elements. Creation of a shorter prolonged service code. The panel created a shorter prolonged service code that would capture physician QHP time in 15-minute increments. This code would only be reported with 99205 and 99215 and be used when time was the primary basis for code selection. Okay? So basically, in summary, time is going to be my prevailing factor when I report these codes in 2021 and when you report these codes in 2021. Is there any questions on those? Okay. All right. For those who are watching, my class is answering no. All right. In your chat window. Okay. So tonight we're going to be looking at some coding scenarios, and I have an assistant that's going to be helping me tonight. When we look at these, she's going to help me get to the answers. My assistant, are you ready?
I'm ready.
Okay. For code 99203, the history level is what? Everybody go to your CPT book and go to code 99203. Okay, answer. Unmute your mic and answer, please.
Do you mean like a detailed history?
Detailed history is the answer I'm looking for.
Okay.
Am I right, Terry?
Yes, you are.
Thank you. All right, moving along. The examination would be what?
Detailed.
Okay. And the MDM is?
Low complexity.
Very good. For 99204, what do we have for history?
Comprehensive.
Okay, and the examination?
Comprehensive.
And the MDM?
Moderate complexity.
Okay. All right, and then for 99205, what would be the history be?
Comprehensive.
And the examination?
Comprehensive.
And the MDM?
Complexity.
Okay, so the reason for that exercise is to make sure you can identify in each of the E&M code sets what the three levels we're driving at are. Okay, so you'll know exactly what you're looking at. All right. So with that said, I'm gonna need somebody, a group of whoever. Somebody grab your ICD-10 book. Another person grab your CPT book. Well, just another person. Everybody do it, and tell me. But I need probably at least 2 or 3 people looking up the ICD-10 code for this scenario. Okay. 53-year-old new patient presents for initial office visit to discuss a surgical vasectomy for sterilization. The history and examination are detailed, and the MDM is of low complexity. What is my CPT code? And what is my ICD-10 code? And so I'll give you a second, and then Terry's going to tell us if we're right. Okay?
9203.
That is for the CPT code, and Terry, is she right?
That is correct.
Okay, and then somebody's going to tell me what my ICD-10 CM code is. Okay, what's the main term you're looking at for this diagnosis code?
Sterilization. Vasectomy.
So it's an encounter for visit, right? Sterilization, was it done on this visit? Are they discussing it? What are they doing? Okay. All right. So based on that, is it going to be a Z code, Terry? Don't give them the code. Just tell them if they're close or far or what.
Yes, it is a Z code.
Okay, so it's going to be a Z code. So with that said, you know exactly where you're looking, right? So remember, for those who are coming from the I-9 world, we used to have those V codes for those kind of services, but now there's Z codes.
Z31.84.
What do you think, Terry? Does that sound right?
No, it is. No, it is not. And Rob is in. You're close, but not quite.
Or somebody's typing it in chat? Okay.
Yes, she had Z30.2.
Okay.
Is it Z30.2? No.
Okay. Go ahead and tell them the answer. So everybody can go there.
It's Z30.09, counseling for contraceptive.
Okay. There you go. That's the code. All right. So write that one down and do some practice on trying to figure out how you got there. Okay. So the next scenario says a 4-year-old new patient presents for the removal of sutures from an appendectomy incision made 10 days earlier in another city. The physician conducts a brief history and examination prior to removing the stitches. Okay. Everybody look up the CPT code. Probably two persons. You can digress and look up the ICD-10 code if you're comfortable with looking up E&M. So it's a brief history and examination. So the history is brief, the examination is brief.
And then 202? No. The ICD-10 code would be Z48.02.
Good job, you got it.
Is the CPT code 99211 because they already had been seen, so you're not charging for. Oh, are you supposed to be 99201?
Say that again, Jennifer.
Yeah.
You fade out. Jennifer? I lost her. Did anybody pick up what she was saying?
Can you hear me?
Yeah, go ahead.
It's a 99201.
Can you hear me now?
Yeah, I can hear you. Go ahead, Jennifer.
99024.
99024. What do you say, Terry?
99. Yes.
No, that's wrong. Someone else said it.
99201.
Yes, that's correct, because they're a new patient.
Very good. New patient, okay? All right. Now, everybody understand how we got arrived at Z48 for that diagnosis code, right? Okay, it's a post-surgery, so you that's the code with you of choice if you were doing like an open wound repair or something like that, and they're coming back for a follow-up visit. You would not code that Z48 code. You would have coded what? ICD-10 class. The folks who were in my ICD-10 class, you know this answer. You would have coded a subsequent code, right, class?
Yes.
You code the open wound visit, but in this time you're going to be coding it as a subsequent visit, okay? For ICD-10 rules. So only time you're going to code that Z48 code is when you have situation like exactly like this. A surgery, they're coming back to remove sutures. All right. Next scenario says, a 23-year-old man who's a new patient has an initial office visit for severe depression reported as first listed diagnosis. So remember the diagnosis code because I have to flip to the next screen. That has led to frequent thoughts of suicide in the past several years. Okay. Several weeks actually. And is acute today. More than an hour is spent discussing the patient's problem and options. Past medical and family history is negative. So they review the past medical and family history. The social history reveals that the patient suffers from sleeplessness. So they review the social history and smokes between 2 and 2.5 packs of unfiltered cigarettes a day and has for 5 years. So this has been an ongoing situation where they're smoking. He drinks 10 to 12 cups of coffee and denies current use of drugs. So they just went over past family and social history. Okay. The actual patient record continues and indicates that a comprehensive history and examination was conducted and a high MDM. So they're telling you right off the bat what it is. I mean, medical records is not going to be that straightforward in the real world, folks, but this one is. It's telling you comprehensive history, comprehensive exam, high MDM. What is my evaluation management code? Just code that for me because it's a...
You're right.
Okay. We'll bypass the ICD-10 code for now. Okay. A patient, 10-year-old boy, is brought in by his father for a knee injury sustained in a hockey game. The knee is... Yes.
Hi, this is Jennifer. Before you go on to number 7, can I ask you a question about the previous one that we were working on?
Which one?
The one with the sutures.
Okay, let's go back to it.
Number 5.
Yeah.
Okay, number 5. The reason why I'm asking that question is because of the way that I was informed code. In the new patient status it's saying that the patient presents for removal of sutures.
Mm-hmm.
So they already had the sutures in. this patient is coming back to the physician's office to the fact that everything else you don't. Our understanding is you charge for sutures that already been put in by the same provider. I'm not understanding how it came to be a new patient.
Okay. The key word. It says made 10 days earlier in another city.
Okay, so yes, if they, that was the key word.
That's the key.
That's what it said.
You know,
Okay, I got it. I didn't see that part. I was looking. Okay.
yeah, that's the key. All right. 10 days earlier in another city. So this is not their doctor. This is not their doctor. Okay. All right.
Okay, go ahead.
Okay, great. All right. Where do we leave off at now? We were going over number 7. Is that where we were?
Yes.
Okay. So a new patient is a 10-year-old boy is brought in by his father for a knee injury sustained in a hockey game. Okay. The knee is swollen and the patient is in an apparent pain. A detailed history and examination are obtained. A diagnosis of medial collateral sprain of the right knee is made. Low MDM complexity. What is my CPT code?
99203.
Yes.
Okay. Anybody else has questions on that? Okay. You see, these are very straightforward scenarios, right? But we did one hard one last week that we had to break down. So this makes up for it. A 41-year-old woman new to the office complains of headache and rhinitis of 4 days duration. The patient states that she has a problem with her allergies during the season for years. Okay. An expanded problem focus history and examination are done. Straightforward MDM complexity. Diagnosis was grass pollen allergy. What's my CPT code, class?
99202.
Terry?
That's it.
Okay.
That's right.
All right. Somebody give me one of the diagnoses. Give me headache. What's the diagnosis for headache?
R51.
R51. But what's my final diagnostic statement? Grass pollen allergy, right?
Yeah.
Okay. In the real world, would I call the headache and the rhinitis?
Rhinitis or, yeah, rhinitis.
Would I call them?
Yes, you can.
Okay. Yeah. So you can code. You got to look at your office, you know, and see what they're telling you. But more than likely, these are your complaints, right? So they're going to be listed as your admitted diagnosis or your reason for visit codes.
Oh, the allergies.
Say again?
The allergy.
The allergy would be the PDX, right?
Yes.
Okay. Yeah. All right. And then, so with that said, that would be my main PDX. But some cases, rare, but some cases, you may have to code the symptom codes. Here's why. You have situations where you have other things that might be performed on the patient. For example, what if they did a CT scan of the head? You need a diagnosis code to back that up, right? You have headache, right? To qualify that. Everybody follow? And right, so that is one way to look at that too. So sometimes you run the edits and it comes back and say you do not have a supportive diagnosis code for that CT scan. So then you have to code headache to kind of quash that edit. Okay. Last one. 17-year-old football player comes to the clinic for 50 milligram gold injection for a left anterior cruciate knee sprain that occurred last week. The injection was given by the nurse. Only the nurse sees the established patient. Code only the E&M service and the diagnosis code.
99211.
You got it.
Okay, very good. You're right on top of it tonight, Jennifer. All right. We're just doing the E&M tonight anyways. A patient was in an automobile accident and is complaining of a minor headache and no apparent injuries. Disregarded gathered by bystanders states that the patient was not wearing a seatbelt and hit his head on the windshield. A 15-minute loss of consciousness was noted. The patient was diagnosed with a concussion. The patient was then admitted for a 24-hour observation to rule out head injury. A comprehensive history and examination were performed. The MDM was of moderate complexity. What is my CPT code?
99204.
What was that?
I didn't.
99204.
No,
205.
no.
Comprehensive history and exam. So the history is comprehensive, the exam is comprehensive, and the MDM is of moderate complexity.
99204.
99204.
What kind of patient are they? What kind of patient are they?
New patient.
99219.
Yes,
Very good.
Because it's
observation.
Very good. You see, you guys got to drill that in. Patient type, place of service, all that stuff. Remember those 3 factors. You got to get that in your head before you start looking at the medical record.
Oh, man.
Okay? A 45-year-old man was sent, this is fun, right? Was sent by his PCP to an orthopedic surgeon's office to render an opinion for acute pain and stiffness in his right elbow. In his problem-focused history, the physician noted that the man was a farmer and used his right hand and arm repeatedly, lifting heavy objects. The patient had no other complaints and reported to be otherwise excellent health. The patient described the pain as severe and unrelenting, and it prevented him from using his right arm. The problem-focused physical examination noted the man's slightly swollen right elbow with marked pain and movement. No other problems were noted with his right upper extremity. The physician diagnosed the problem as elbow tendonitis and bursitis, recommended warm compresses, and gave the patient a prescription for anti-inflammatory medication. The MDM complexity was straightforward. Where am I at?
9212.
99241.
99242.
Nope.
Okay. Somebody tell me that. Hold on. For the new, hold on.
The patient was in the hospital.
Where is the patient at? Say it again, Jennifer.
I said it's office outpatient. I said that.
Right answer was said.
The right answer was said, Jennifer.
I said 99212.
No, I was asking about where was it set in?
Oh, the patient was in the hospital.
His office.
Everybody agree?
No, it was a surgeon's office. It was sent by his PCP to the surgeon's office.
Okay.
99241.
All right.
Yes.
What's the code? 9924. Okay. Why is it 99241?
Yes.
Why is it 99241? Okay, so it's a consultation visit. Okay. Consultation visit. So, you have to break down the type of visit, where they at. Everybody following? Did I lose anybody? Janelle, Giovanni, some folks I'm not hearing from. Maria, you guys are getting it?
I'm with you.
Okay. Who said I'm with you? Who was that?
Angie.
Oh, Angie. Okay. Janelle and Maria. Giovanni. Okay, I'm not hearing them. There must be something going on with their phone.
No, they're typing, they're answering you with their.
Oh, okay. They're not okay. So their mics must not be working then. Okay. All right. Mary, I can't give you notations right now. Do you want me to notate something, Mary, or is that a mistake? Mary? Okay, I didn't hear you, so I'm going to keep moving. All right. Okay. before we go into this, I need to pull up the anesthesia. Some of you already see this lecture, and which is okay, and some of you have not. So for the ones who have not, this is going to be new to you. Is there any questions on E&M before I move forward? Now's the time to ask. If you don't want to ask here on the live and you want to catch me in a corner and say, Kevin, I have questions. Yeah, the gray box on my screen is, I don't know, Mary, I keep hitting decline on that, but okay, yeah, I just hit decline on it. But I want to make sure if you have questions on the E&M and you're just not getting it, please don't be shy, don't be bashful. If you want to wait around after we're done tonight and ask me questions pertinent off the air, off whatever, do that, okay? I rather make sure that you are comfortable in your skin and knowing how to code these rather than, not knowing. If you're in school currently and you're currently taking the course, that's something else. But if you're already in the field or you preparing for your CPC examination or CCS and you need guidance, please ask. All right. I want to make sure you pass your examinations. All right. Please ask. Okay. With that said, we're going to move it right along. We're going to talk about anesthesia coding, which is the next section of your CPT book. This is a lecture that I presented some time back. We went into modifiers and that kind of thing. And there's a video out there on that that I circulated to a lot of folks. Hold on, there's a question. I'm just seeing the question. Let me go, hold on. Let me see if I can capture all the question. Do any of you all know how to code this? Okay, Whitney, let's take that question when we're done, okay? I will answer you because I need to really look at that question some more. Since it's very lengthy. So I'll look at that question at the end of the lecture tonight. So just stick around and I'll try to answer you. Okay, so for those who did the modifier video that looked at it and good, you will have a neat new review tonight. And for those who have not seen this, this is going to be brand new to you, okay? All right. Does anybody not understand what anesthesia coding is? Everybody has an idea what anesthesia coding is. Have heard of it, right? Okay. All right. With that said, anesthesia services are breaking down into a time component. There's the main driving force behind it is time. And there's a definition of anesthesia that I need you guys to remember. Anesthesia starts when the physician enters that room and the patient is no longer under needed treatment by that physician. Okay, so that's something you always got to keep in your back of your head as you move forward with this. Okay. The CPC examination have about 8 questions on it, I believe. Time reporting, qualifying circumstances, physical status modifiers, anesthesia for surgical diagnostics, and obstetric care is pretty much what's covered there. Terry, you're recently taking your test. You want to give any insight on this section? Did you see anything different?
No, definitely time modifiers, qualifying circumstances, and sequencing.
Okay. All right. There you have it. For somebody who just took her test and passed it, so that's fresh information. What is anesthesia? temporary loss of sensation or awareness that is induced for medical purposes. Okay, so you have different types. You have general, regional, local, and MAC. Demonstration, local anesthesia, metacarpal, metatarsal, digital blocks, regional anesthesia, monetary anesthesia care, which is MAC, and general anesthesia. Okay? A drug-induced loss of consciousness where the patient's unconscious and has no control of their airway. That is general anesthesia. You have regional anesthesia, which includes blocks, spinals, and epidurals. Spinal anesthesia is an anesthetic agent that is injected in the subarachnoid space into the cerebral spinal fluid in the patient's spinal canal for surgeries performed below the upper abdomen. Epidural anesthesia, remember the location for the spinal, right? Upper abdomen. Epidural anesthesia, anesthetic agent is injected into the epidural space. That's the location for epidural. All right? A small catheter may be placed for continuous epidural. An epidural can also remain in place after surgery to assist with postoperative pain. Nerve block, an anesthetic agent is injected directly into the area around a nerve block sensation for the region the surgery is being performed. Commonly used for procedures on the arms and legs. So therefore, what is local anesthesia? Local anesthesia is used for minor surgeries. Local anesthesia, the services are included in the CPT code for the surgical encounter. There would not be a separate code for anesthesia services with this one. Okay? So local anesthesia, we wouldn't be coding a separate code for anesthesia services. Just keep that in mind. Sometimes they just do minor stuff to numb the pain. A little kid maybe has sutures in their hand. They don't want to hear the cry. They numb the pain. Or an adult with a little minor cut, but you know, pain. They have a low pain tolerance, so they might numb the area to do that. All right. What is MAC? MAC anesthesia services where the patient is under light sedation or no sedation while undergoing surgery with local anesthesia provided by the surgeon. The patient can respond to purposeful stimulation and can maintain his airway. This service is monitored by anesthesia provider who is well prepared at all times to convert to MAC to general anesthesia if necessary. Okay? Conscious sedation is a combination of medicines to help you relax. It's a sedative and is used to block pain. An anesthetic during a medical or dental procedure is usually utilized. You will be probably staying awake when conscious sedation is given. All right, you may not be able to speak. However, conscious sedation lets you recover quickly and return to your everyday activities soon after your procedure. You see that often in the ER, emergency rooms, you see this often. So what's the difference between conscious sedation and general anesthesia? Conscious sedation, as several visits, a procedure may be performed. So this can be over and over again, recurrent theme. Patient is cooperative, right? But anxious and fearful. Generally, no extensive investigations are required. No pre-medication is required either. Patient is conscious and in contact is maintained. Is maintained all the way. Airway is maintained. No mortality. Recuperation period is probably 1 to 2 minutes. So jerk him, stick him, suture him up, him or her. You're done. Okay. See you later. Patient feels he's control of the situation the whole time. General anesthesia, single setting, once in a lifetime procedure. Patient is uncooperative. At least basic investigations are a must. Pre-medication also required. Ventilation is required. 99% success rate is reported. It's a time-consuming procedure. Patient cannot control the situation when general anesthesia is given. With that said, there's some modifiers that goes with anesthesia, and these are listed in your CPT book. I'm not going to go over these too much tonight because we did a modifier class. And for those who did not get the modifier video, I suggest you go and watch it. If you have not seen it or you don't have access to it, let me know. Send me an email, medicalcoderkevin@gmail.com. Somebody type that in the chat for me. Medicalcoderkevin@gmail.com and say, Kevin, I need to see the modifier video because we're going to be utilizing modifiers as we advance throughout the CPT course. Okay? Well, I don't call it a course, a study session. Okay? And see, these are your modifiers here, but you need to go back and watch that video. All right? And these are your qualifying circumstances. Okay? And these are some pros and cons when it comes to anesthesia services. Usually done by a licensed physician or anyone under the direct supervision of physicians, CRNAs, and those kind of people. All right? So what is included in the services? Preoperative work, postoperative work, anesthesia care during this procedure, postoperative, and the administration of fluids and or bloods, usual monitoring services such as ECGs, temperature, blood pressure, all of those stuff is in there. Time. Time is utilized in calculating anesthesia services. It's imperative to know the definition of time. Okay? Anesthesia time, we went over this, begins when the anesthesiologist begins to prepare the patient for induction of anesthesia in the operating room or equivalent area and ends when the anesthesiologist is no longer in personal attendance, that is, when the patient may be safely placed under the post-operative supervision. You need to know the definition of time when it comes to anesthesia. I believe it should be in your CPT book, but if it's not, I would take out your phone and take a picture of this. This is my definition. This is the best way to remember it for me at all times. Time is calculated, right? And it's imperative to know the definition. It begins when the anesthesiologist begins to prepare the patient for induction of the anesthesia in the operating room or equivalent area and ends when the anesthesiologist is no longer in personal attendance. That is, when a patient may be safely placed under post-operative supervision. So that anesthesiologist, beginning of the surgery, he or she, they go in, they administer the anesthesia, and they're pretty much sitting around waiting, right, watching everything while the surgeon performs his or her duty. Once the surgeon is done, they do what they have to do to get this patient, back to normal being. Awoke, risen, eyes open, talking, can repeat the last four of their social security number. They know that they're done. They're good once the patient can do that generally. Right? So, here's some factors I need you to remember. To calculate time, there is certain elements that you have to remember. One is base units. The other one is time, which we just went over extensively. Physical status modifiers. And so it's base units plus time plus physical status modifiers equal total units. Right? Base units plus time equal total units. That is how you're going to calculate reimbursement. Okay? For commercial, base units plus time plus physical status modifier. For Medicare, base units plus time equals total units. That's the difference. Anybody lost yet? Okay, so now where are we going to get this? These, numbers, that we're talking about. How is this all going to revive? Well, your medical record is going to give you the time. We know that. That's It's pretty much set. But if you open your anesthesia book, your CPT book rather, class, I said anesthesia book, and you go to just any particular code in your CPT book for anesthesia services, you remember what those are, right?
Yes.
Right in the beginning of your CPT book, right? And it's a very easy set of codes to procure. Okay, did you have to calculate anything on your test, Terry?
No,
No, you did not. Okay, all right. But if you become an anesthesia coder class, any one of you, then you will be well into the game, because by the time you get into that realm of work starting to work, you would have had the basics down in order to know how to code, and you will know that Kevin had taught you this, so you will know exactly what to do. So we use a guide, relative unit guide, that is there to guide us, to tell us exactly how to come up to these values. Every one of your codes in your CPT book on anesthesia has what we call a base unit. A base unit. So every one of these codes has a base unit. Your guide is the one that's going to tell you what is a base unit for every CPT code underneath the anesthesia section. Your time, again, I remember I said you arrive at that from the actual medical record. Your physical status modifier is going to be calculated based on what's in your guide. Okay? So your physical status modifier, that's your P1, your P2, your P3, your P4, your P5, your P6. All of those is going to have a numerator attached to it. That's what he's going to utilize to add these up. Okay? So, for example, looking at code set 00100, that's a procedure code. The basic unit value is 5 for that code. 5. Okay? So it's going to be 5 plus time. So the time for this is reported in 6 units. How do you arrive at that? Because time, when you're calculating time, right? Time is reported in 15-minute increments for anesthesia. 15 minutes increment. 1 hour of time equals 4 units. 1 hour of time equals 4 units. Right? An example for a 45-minute procedure from start to finish would equal 3 units of anesthesia time. So do not estimate the time or round up inappropriately. So 1 hour and 30 minutes on the other scenario that we're looking at here is equal to 6 units, 6 time units. So the calculation would read base units equal 5 plus 6 for time units equals 11 total units. Okay? And there you have your Medicare reimbursement rate. Notice we did not include physical status modifier in here. So this is a Medicare reimbursement tool. All right? Now, the other situation that comes into play with anesthesia coding is called conversion factors. Conversion factor is something that you're going to arrive at, you're going to find on the Medicare website, cms.gov. You can go and find your values for these. So you find it for your locality. If you live in Florida and you live in Fort Lauderdale, or if you live in Connecticut and you live in Bridgeport, or wherever you live, all of this is going to be out there on the web. So you look for your locality, you get your dollar amount. So it's going to be 11 times whatever that amount is equals your conversion factor, right? And this is your maximum paid. So for this claim, the anesthesiologist will get $535.70. So that's how that's arrived at. Now, I don't know if there has been new software that came out since the last time I did it. I did it years ago when I just started coding, donkey years. And it's been a while, but it's still fresh in my head and I'm able to relate to you tonight. Okay? So something that will never leave me because this is something that I did for quite some time. And it is very easy to remember. Just remember, if you want to be an anesthesia coder, you can. This is how you do it. Okay? You just got to remember that you need to go to cms.gov. And if you're in a field, you'll be provided with a guide and all of that stuff. So all the tools necessary to make sure you do your job properly. All right? So don't to worry about that. But like you said, Terry said, and I think somebody typed that there's no calculation on the test, so that's good for you. Okay, so you don't have to worry about that. But you have an idea, or you can say in your resume now that you have knowledge of. That's the key. You have knowledge of anesthesia coding because I just taught it to you, right? So you go to your interview, you can say that. All right, and this is what a worksheet will look like for anesthesia coding. And like I told my previous class, they probably have something more advanced now because since came out, there's been EMRs, electronic medical records that are out there. So there's probably more advanced tools now that are out there for this. But this is something that I used back in the day. Okay. And this is how it will look on a claim form. This is your diagnosis. Okay. Your date of service, your place of service, the CPT code for it, your physical status modifiers, your AA, and I'm pointing to diagnosis number 1. That's how I'm reporting it on the claim. And then whatever dollar amount is amount, so would be over here. And that's it. Any questions when it comes to that? Any questions? Okay. With that said, let's keep it moving. All right. So what I want to do right now, because I want to kind of have you go to your CPT book. So everybody go to your CPT book. So there's no PowerPoint for this. Okay. So you need to have your CPT book open, please. And if for some reason you have not tested yet, is anybody on with me tonight that is going to be testing for CPC sometime in the future or CCS? Speak up. I see one, Judy. CCS, okay. CPC, okay. All right, good. All right, so good. We do have testers on the line. That's awesome. All right. So with that said, I don't know if you have done it yet, but I need for you to get familiar with your book because that's the only thing you're going to be utilizing when you go for your tests, okay? If you have not tabbed yet, you need to do that as soon as possible for you, whatever benefits you. You know, if the tabbing works for you, use it. I'm not forcing you to. The tabbing works for you, utilize the tabbing system. If it doesn't work for you, don't use it at all, okay? So whatever you think that works for you, but I suggest tabbing. It depends on what type of book you have because I don't know, some books you probably can, it's color coordinated. You probably can know based on the color format which sections you're in. But the idea, the whole idea is for you to get familiarized with your book so you know exactly what section you're going to end up in at all times. We're going to be breaking down this book, and you need to know exactly where to go quicker, faster, efficiently, so you can do well as far as timing on your tests. After you bypass the anesthesia section and the E&M, the next section of your CPT book is surgery. Now I'm utilizing the 2019 version. Someone page 77. Okay?
71 in the 2020.
71 in the 2020. Okay, thank you. All right. But prior to that, right in front of it, starting on page 72, actually, is your surgery guidelines. Your guidelines. And it's very important that I could have put this in a PowerPoint, but I choose not to this time around because I did go over this when we discussed modifiers. For those who are in the modifier section with me, remember I talk extensively about the surgical package. Remember that? And so therefore, it is very important that you go to, for many, page 72, and then the 2019 version, you go over what the definition of surgical package is. Make sure you have that down, okay? Make sure you know what is included in the surgical package and what is not included. And make sure you know how you can separate a component if the patient decided to go to somebody else during that whole global period. So you know we have 0, we have 90 days calendar time, right? So you have a situation where a patient may have had the surgery done by Dr. Joe at St. Joseph Hospital, but the patient decided to follow up with Dr. Mary in Cleveland, Ohio. So somewhere else, okay? And so therefore now the surgical package would not be billed as a bundle package when you submit it to the insurance carrier, because we know at some point in time, patient's follow-up visit was in Cincinnati, not in Rochester, New York, okay? So therefore, the package is unbundled, separate. And we talked about in the modifier setting, when we did the modifiers, that you have modifiers for that. You have certain modifiers that will help you break that down. Again, go back and look at the modifier video. All right. So you have the evaluation management services, right? You have the local infiltration, metacarpal, digital block, topical anesthesia. You have immediate post-operative care following dictated operative notes, talking with family members, writing orders, evaluating the patient in the post-anesthesia recovery area, typical post-operative follow-up care. All is inclusive in the surgical package. All of that is inclusive in the surgical package. So it's very important that you remember this, you recite this, and you take this, make that be a holy grail when it comes to the surgical package. Any insights, anyone, you don't have to be Terry, that took the CPC recently, that have any insight on what was on that test when it comes to the surgical package? Terry?
I don't remember there being anything on the surgical package.
Okay, all right. Somebody's asking, where is the information for this study group located? I don't understand the question. You're in the study group. Procure? I don't understand the question. Like the HW. Are you saying like the homework? Okay, we have not distributed any homework yet. Today is our second day of meeting, and so therefore homework has not come out yet, but thanks for asking, because everybody, you're going to be having homework for next week, Monday. Okay, it's not going to be much, probably about 10 questions, just to make sure you understand evaluation management coding. So when that is done, Recur, what I'll do, everybody will get an email. And for those who did the ICD-10 class with me, know how that shows up. It will shows up as a Google Doc form in your email, and you'll just answer the questions, and most likely the system will tell you if your answer is right or wrong. Sometimes that Google form doesn't work too right. Sometimes your answer is right, and for whatever reason it marks it wrong, but that's the best way for me to do it right now. So, if you know you're right, just ignore it until we review it on Monday night. But utilize it right now, okay? For the class, everyone need to know that we're utilizing the step-by-step as a guide to go over these lectures. If you have the step-by-step on your bookshelf, or if you want to order it, that's up to you. But a step-by-step book is what I'm utilizing as a guide to help drive these classes. Okay, I will take real life material and insert in the lecture because I want you guys to get real life experience. So I will take real life, like CPT assistant in this case, will be inserted. And if God forbid we're doing something with ICD 10 CM, I might insert coding clinics to help guide you. What's the exact name? I'm not actually sure what you're asking. You mean the name of the book? The name of the book is Step by Step. Okay. Thank you, Terry, for letting her know. Okay. I thought I told everybody this the first day of class, but I know I understand the ones that are new, but yeah, this was told to you all. But anyways, step by step. So make sure you have that if you want to. You don't have to, because as you can see tonight, what I do is just take the material, extract it, and put it in PowerPoints for those who don't have, because I know not everybody's not going to be able to afford the book. And I'm not forcing it on you. So that's why I decided to get a digital versus an actual handbook. That way I can just copy and paste into the lecture, and you guys can follow along easy that way. Any other questions? All right, moving right along. Back to the surgical package. So remember exactly what's in your surgical package at all times for coding. Now, you may not have it in your test, but when in the real world, you need to know this. Okay, this is paramount to you coding. For example, if you want to become a surgery coder, which pays top money, just like the inpatient coder, then you need to know this. Okay, you need to know what's in your surgical package. You need to know how to unbundle it. You need to know what happens when you unbundle it. You need to know all of that stuff. Okay. Can't hear. Can everybody hear me?
Yes.
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 Okay. I'm not sure then why you're saying you can't hear, because check your mic, your speakers, to see what is going on there. Next thing you need to remember is separate procedure. Does anybody know what a definition of a separate procedure is? What is the definition of a separate procedure? Put it in your own words. Don't give me the book terminology. In your own words.
When a patient actually came in to the hospital to be have surgery for one thing, and the surgeon actually did a separate procedure at that same time on something else that they asked.
Separate site, it could be separate size, separate body system, separate organ system, whatever. You got it. You got it, Jennifer. Thank you. Everybody follow that? So read the definition of separate on my books, page 72, 2019. Read the definition of a separate procedure. Make sure you have that down. Again, I could have put this in a slide, but it's right here in your book. So it's very easy for you to guys to go back to and look at. I need you to get familiar that, hey, listen, what I'm going over is in your book. So when you're testing, you will remember, you will be driven home to you that is actually in your book. You don't have to sit there and try to always, but just like how she was able to dissect it and remember exactly in her own way how to put it, you're good, you're golden. Okay, rather than try to look at this lengthy paragraph when you're in the middle of a time test. So that's where you could possibly go wrong. You're in the middle of a time test and you're trying to read the paragraph now, sometimes for the first time, some of us, right? Because we do these last minute studying, and that's not a good way to do it. So make sure you follow that. Now, along with that, every section of your book, you pretty much have unlisted procedures, unlisted services, unlisted something, right? That means a doctor perform a procedure on a patient, and for whatever reason, it is not quantified, it's not stated. You can't find a code for it anywhere in your CPT book. Now, if that is the case, you do report an unlisted code from that particular section of the book. If it's a digestive system, you report an unlisted code. Whatever section of the book that you're coding from, whatever system you're working on, just remember, when you report an unlisted service or procedure, and you send it to the insurance carrier, something else has to go along with it. What is that? Somebody.
Documentation.
Documentation in form of a medical record, a copy of your medical record, thank you, Terry, or something of the sort to help guide the insurance carrier as to why is it you did not come up with a code for that particular situation. Special report, as it's called. Thank you, Rosen. Okay. All right. So those are the things that you have to worry about when you're coding surgery. You have to worry about that. So with that said, keep moving. And we're going over the book. Now you have a look at the unlisted procedures. Your surgery section starts now on page, well, for me, 77 or 75 actually of your CPT of the 2019. And every section of the CPT book. Now I'm assuming I have to do this because there may be folks on this line who have no, who have not ever had this happen to them, or actually has somebody go over this with them. So that's why I'm doing this. But every section of your CPT book has it broken down as to the guidelines for that particular section, how to code it, how to quantify certain things, how to do it. The guidelines are there in point blank. Every section, if there's a spelled out guidelines telling you what to do. What I suggest as we go over, as we are reviewing these different sections, starting on Monday, make sure you take the time to get a highlighter. You highlight things in your book that probably doesn't make any sense to you, so you can ask those questions of me. Send it to me ahead of time so I can research if I have to research, or provide CPT assistance if I have to do that. I would prefer that you send me an email ahead of time. Kevin, for tomorrow night's lecture, please go over X, Y, and Z. That way I'll have something prepared for you to go over with you. Everybody understand? Yes, let's type yes. Okay.
Yeah.
Okay, all right. So, and then right after the surgery section, which covers the integumentary, you go into musculoskeletal, and right after musculoskeletal, you go into, what's the next section? Respiratory. Okay, and after respiratory, you have what? Cardio. Okay, and after cardio, you have what? Digestive. After digestive, you have what? Urinary. And after urinary, you have what? Say again?
Male genital.
Male genital system. And after that?
The female.
Female genital system. And after that?
Nervous system.
Okay, and after that?
Eye.
Eye. Which, all right, and after that?
Auditory.
Auditory. And after that?
Radiology.
Radiology. And after radiology, you have?
Pathology.
Pathology, which is your labs, right? And then after that?
Medicine.
Medicine. And after medicine, you have a category, set of category codes. Okay, so you just got familiarized with the book. For those who are brand new to it and you don't have no clue, the CPT book, this is it. And everybody here has a copy of the CPT book. Yes, I have 27 people on the line right now. I should have 27 yeses. I'm looking. 27 yeses. Everybody type. Okay. All right. Because if you don't, it doesn't make sense here in my class, because you're going to be doing hands-on training. So you need to have whichever edition, 2019, 2020, you need to have a book, because this is how you're going to be quizzed, tested, and I'm going to make sure things are driven in and that you get it. And I'm going to be utilizing real-life examples, including CPT assistance and all that good stuff, to make sure every section is understood and you get it the first time around. So if you're struggling in one particular area or the other, you come to a good class, because I'm going to go deep into this stuff to make sure you get it. Okay. And that's where we at. But I'm going to let you guys go early tonight. If there's any questions After we hang up, I'm gonna stick around for about 5-10 minutes, and you can just stay on the line. I'm gonna end the YouTube session and all of that stuff. So it's just gonna be me and you talking, as opposed to the world. And you can tell me what's on your mind as far as things you did not understand. And that's how I'm gonna do this every time that we meet, once we have time. Okay. And medicalcoderkevin@gmail.com. Medicalcoderkevin@gmail.com. I think Terry had typed it in for me before. Medicalcoderkevin@gmail.com. So that is what you need to remember. That's the Gmail. If you have questions pertinent, please send them to me ahead of the class session. That way I have time to look up whatever questions you have, and be able to answer them appropriately during the live so everybody can share and learn. Okay? Because I don't want to be stopped and then we have to take time out of the lecture to go back and look it up and all that good stuff. So send them to me ahead of time. And if it was from a prior lecture, that's fine too. All right? And again, remember, look out for your homework for this weekend. Okay? You will have a little quiz, about 10 questions on evaluation and management services. All right? And so look out for that. And you will just basically answer the questions, just help you. So everybody, you have a blessed night, and I'll stick around here, and that will be it. Have a good weekend when it comes and all that good stuff.
Night, Kevin.
Good night. Thanks. Oh, thanks, Sari, for your help tonight.
You're welcome.
Thank you.
Thank you.
All right.
Carrie, are you still here?
Think she just left.
Anybody else on?
I am here. Just give me 1 second. Let me end the YouTube session. Yep, there's people on the line still. There's 12 people here. I'm just trying to find the YouTube thing so I can end it. Give me 1 second.
Nothing.
Can I help with that?